surgery I had recently, and I was actually amazed at how little I had to do.
All right, good morning, everyone. Thank you for joining us. I'd like to begin by introducing our team. We have Lydia Homovich, who is our policy analyst, and Sophie Fisher right here.
Good morning, everyone.
She is our membership director and operations director. She is also an attorney and is doing a lot of the updating of our policy and research reports right now. So you will see some of those reports coming to you in draft form for feedback. So just wanted to give everyone a heads up. You need to contact Sophie. Her email address is sophie@ctel.org. All right, so today is a day that we are going to focus on follow-up conversation that came from our meeting in June with Secretary Kennedy's office. So just to give a background, we are today going to be addressing the clinical workforce shortage and the impact that that is specifically having on digital health policy. Why are we having this conversation as CTeL, the Center for Telehealth and eHealth Law? So CTeL had a meeting with Secretary Kennedy's office in June. Joe, I think FICA was there, a handful of people that were at the table here and some on the line right now. And we were asked, what are the three issues that are impacting expansion and utilization of digital health services? CTeL named one, which is obviously lack of consistent Medicare reimbursement or waiver permanency as it applies to 1834M. Number two is the issue pertaining to DEA and the prescribing of controlled substances. And the third issue is something that we haven't heard before our community discuss, and that is the clinical workforce shortage. And we provided research that showed that we have a clinical workforce shortage, and digital health, which has traditionally been that bridge that has been able to bridge care from patients in underserved areas to care providers, is in some situations no longer an option because hospitals and health systems no longer have clinical workforce that could be at bedside, and they cannot staff those digital units. So that is problematic. And so CTeL, as a digital health and policy research institute, presented this issue. And Secretary Kennedy's team said, well, what could we do about it? We suggested, as an educational tool, declaring a public health emergency for the clinical workforce shortage. And the next question usually is if you're going to declare a public health emergency, then you are asking for something. You're usually asking for funding, you're asking for a waiver. What is CTeL asking with this very broad PHE? And so we came back and we said, let's bring together the community. So we brought together the nursing community, which was represented by 7 different organizations: American Medical Association, PAs, and hospitals and health systems that sat around the table in September. So I believe there were a total of 50 organizations that were present. And then we had some really great conversations. We had a federal a federal attorney that focuses on public health emergencies that was represented from Nixon Peabody that talked about jurisdictional issues that were at play if a federal public health emergency was declared. Then there were questions about if there were policy successes that were won at a state level by these different licensure communities, would that somehow redact or negatively impact those successes? And the attorney that represented Nixon Peabody said, no, that's not how PHE jurisdictions work. So we then had a series of questions and research questions that were presented to us, mainly by the nursing community and others that sat around the table, that we had to go do research on. And then we had a follow-up meeting in October. In that follow-up meeting, which was virtual and was recorded, we were able to address those very specific questions that were initially asked in September. We mentioned that we were going to, as a result of that meeting, we decided that we would not ask for a specific waiver because that wasn't necessary, because we were asking for such a broad PHE. And so rather than a waiver, we were asking for HHS to put in place this PHE, so then they could put in place a coalition that was diverse, representative of all of these different clinical care providers on how to address the clinical workforce shortage. And that would be our request of HHS. That, of course, happened pre-conversation. This conversation happened before the reclassification of professional degrees, which has caused concern among nurses and PAs and others that have sat at the table with us over the last 6 months. So this conversation was started way before this reclassification. So I just want everyone that is here, both in person and virtually, to know that CTeL understands that there are competing interests at play, but we need to follow up with HHS regarding our request. And so today is a conversation that we are going to have talking about what is our ask of HHS. And as we do that, we need to keep in mind that CTeL is not advocating for a specific licensure group. We are not advocating for, as a research institute, we don't typically advocate for anything. We are putting forth a request followed by research and information to support our request. And then based on the outcomes of this, hopefully, coalition that is created by HHS, or the declaration, which would be a PHE, those individual licensure groups could use, but we understand that we are not interested, nor do we represent any of these clinical licensure groups. But that is the context of why we are involved as it applies to digital health. Does anyone have any questions? Okay.
This is Kelly. Sorry, I'm having to join virtually today. I don't have a question, just to let folks know that this also impacts dietitians, and we did request a meeting with the DOE. They declined, saying that they're in this period. So if anyone was trying to get a meeting, they declined for us anyway.
Thank you. I'm sorry, Kelly, I didn't know you were here. So thank you for, and so we're now going to just go around the table real quick, and everyone is going to announce themselves, and then we'll go to our virtual participants. And it looks like we have 16 virtual participants on the line. For those of you, if you can go on camera, just so we have a face to a name when you introduce yourselves. All right, if we want to begin with Mr. Tate.
I'm Tate Heuer, Vice President of Federal Advocacy for the American Academy of Physician Associates.
Hi, Lydia, Policy Analyst with CTeL.
Rick Masters, I'm the General Counsel for the Interstate Medical Licensure Compact Commission.
And I'm Marschall Smith. I'm the Executive Director of the Interstate Medical Licensure Compact Commission.
Hi, Sophie Fisher, Membership and Operations at CTeL.
Hi, Wes Baju. I'm an artificial intelligence engineer for healthcare. I'm a founder and CEO of Ophthalmics, retinal disease diagnostics company.
I'm Taylor Bacharach-Nixon. I'm a management analyst with the Washington Medical Commission.
I'm Khadija Decara. I'm the policy manager with the Washington Medical Commission.
Micah Matthews, Deputy Executive Director for the Washington Medical Commission.
Guy, Digital Care Strategy Officer for Ballot Health.
Michelle Hager, do you need us to do this?
Oh, no, they're Mike's there.
Okay.
You're good.
Michelle Hager, Managing Partner of Blue Sierras Consulting.
Blake Halliday, Director of Legislative and Regulatory Strategy, Nightingale Education Group.
John McManaman, lawyer, private practice, Christian Bar in Richmond, Virginia.
All right, now if we can go to those that are virtual.
Dave Alber, National Fingerprint Licensing. Hi, Marsh. Hi, Rick.
Good morning. This is Kelly Horton from the Academy of Nutrition and Dietetics.
Lisa Mae Williams, CNO at Intercept Telehealth.
Kim Iles, also from the Academy of Nutrition and Dietetics.
Clarence Williams, Director of Primary Care Community Medicine, Luminous Health.
And I'm Jordana Bernard, Executive Director of Standards and Policy for Savado.
Taylor Daly, Associate General Counsel, Waystar.
Jordan Manzer, Senior Policy Advisor, American Nurses Association.
Paul Yarbrough, UCSF Health, wearing my Giants cap, just in case anyone wonders what city I'm sitting in.
That's early. Carol.
I'm Jess Easterday, Director of Virtual Care at Amplify Health.
Helen Kreger, Director of Telemedicine for Wellness Urgent Care.
And I'm Trina DePel, Vice President of Clinical Regulatory and Quality at CTeL Health.
Zawal Haidari from APA.
I think we have one more. Is there anyone else that didn't say hello? You're on mute, April.
April Noel, Event Manager, CTeL. Hi.
Hey, April. All right. So thank you to those that are attending both in person and made the trip to DC. We're very appreciative of this, those that are involved and wanting to be part of this conversation, and those that are with us virtually. So now that we've done introductions, we're right on time for session 6, which is titled Creating an Actionable Policy Framework for Fixing Clinical Workforce Shortage. We have with us Charla Burill, Senior Director, State Legislative and Government Affairs, Academy of Nutrition and Dietetics. Tate Heuer, is it Heuer?
Heuer.
Heuer, okay, sorry, Tate.
No.
Vice President, Federal Advocacy, the American Academy of Physician Associates. Kim
Krista?
Iles.
Yeah, actually, Charlotte's not joining us. It's Kim.
Oh, okay.
Yeah, Charla will be on. She had an emergency meeting this morning, but she'll be on in about 30 minutes.
Okay. Well, I have you next. So I was just doing an alpha order. All right. So Kim Iles, Senior Manager, Academy of Nutrition and Dietetics. Dr. Margaret Lozovatsky, Chief Medical Information Officer, Vice President of Digital Health and Innovation at the American Medical Association. We have Rick Masters, Legal Counsel, Interstate Medical Licensure Compact. Marschall Smith, Executive Director, Interstate Medical Licensure Compact Commission. And Jean Sumner, Mercer University School of Medicine. All right. So this is a very much roll up your sleeves policy type of conversation that we're going to have. The goal of this is to leave with enough information for the CTeL team that we could produce a request and suggestions to HHS within the first quarter of 2026. All right, does anyone want to start this conversation? Do we have any feedback? I heard someone say me, but I don't know who that was. All right.
Well, I'll
Okay.
jump in.
All right, thanks,
Because
Marshall.
I hate the silence. So that Midwestern upbringing.
Same,
So,
friend.
I guess as I was thinking about this topic and realized the presentation or the discussion I was going to bring really was off target. I brought myself back onto target, which is looking at this declaring a public health emergency and the value of doing such thing, and the potential harm of declaring a public emergency. I think it's as with anything, you can have all the intentions and ideas at the beginning of a project, and by the end of the project, it is usually something different than what you intended or started out to be. So here are some of the thoughts that that I have about this idea of the shortage area, and obviously coming with a bias being the executive director of the Interstate Medical Licensure Compact. I think compacts were a very strong approach to solving part of this problem. We've found in our compact, the physician compact, and it's been mirrored in all of the other compacts, that the traditional idea is that if you create licenses or opportunity for licenses in one place and allow the mobility of that, you're draining point A to gain an advantage in point B. And what we found, and there's a study that was done by 3 economics professors at the San Jose State University in California, and it's published on our webpage. Compact actually does the opposite. It creates additional opportunities to provide physician care in states by expanding this licensure process through the compact. How does that happen? It happens because physicians in border states can do this. It happens because hospitals and facilities can offer their care to patients who normally couldn't get that care. So summarizing all that, and I could go on for hours. I'm like the G.I. Joe from the 60s where you pull my little ripcord and I start yammering, and I yammer for a long time. But I think as we're looking at this or starting this process, I think it's important to stress that there already are efforts taking place to address this issue. And that the declaration of should it be decided that we should declare a public emergency, I think we need to be very, very clear that we've already taken the steps. This is an add-on to the actions that as a community, a healthcare community, we've already started down this path. And this is helping and augmenting our efforts, not necessarily us standing in the woods screaming, we need help, we don't know what to do. And I think we would get a very different result of that by saying we've already taken steps, we're already doing things, we're already actively looking at these. We're doing compacts, hospitals are changing the way that they deliver care. Professionals, the PAs, the nurses, the physicians, the dietitians, everybody else is looking for better and better ways to do this. And we're doing it really well, and we just need help. So that would be those are my thoughts.
I love that reframing, Marshall.
Yeah.
That's awesome. How does everyone else feel about that?
Yeah, my question to Marshall is, so based on those efforts, do you have any quantifiable information that says, okay, based on the 5 things or whatever those are that we're doing X, Y, Z, we expect that we'll be able to close the gap by X amount, X point?
Let me answer the first portion of that question. In terms of the governance structure, we've got 44 states that have enacted the medical licensure compact. There are 43 that have enacted the nursing compact. So we have a structure in place that's almost nationwide, and we think we're going to get there in both professions, which will at the very least create some a catalytic effect that we hope will not cure the problem, because I don't think any one solution is going to do that, but at least to give us an infrastructure by which a lot of this problem can be, as Marshall says, ameliorated.
And the reality is that if we need X number of I'm just going to say physicians, because that's my world. If we need X number of physicians, but we're only churning out Y number year after year, it's never going, because we're always going to have a greater need than we're providing a supply. And that's where I think to me, the addition that needs to be done or the declaring of an emergency is to find where do we get these other professionals? How do we solve this gap? So I think we can get probably, and I'm just throwing out numbers because I really don't have the idea, but we can probably get through the licensing process, and the PAs are now joining. I mean, there are now compacts for almost every single health profession. That's going to get us, let's say 85-90% the way there, but it's getting that last. And how do you do that while preserving the very important framework that we've created, that state licensure and state regulation of medicine is the critical part to this. I don't know. So I think we can get there, but what's that little
delta?
Yeah.
Well, and that's what I was getting ready to say. So from a healthcare perspective, from a rural healthcare perspective, let me say this. We compete with the for-profits of the world, the bigger ones. We can't afford, and we've done several market adjustments to our, intro nursing salaries, and still are not even close to, what Knoxville can pay compared to us, and they're just an hour and a half away. And so we've had to turn, and we've been very successful with it, to international nursing. But now there's issues with that. And the way our CNE has brought the international team in is they brought them in as a community, and we've actually built a community locally so that they would have, almost a family to rely on. We connect them with churches and so forth. So it's like we do embed them into community, because you and I were talking about how hard it is in rural Appalachia.
Yep.
You're either an outsider or you're in. So she has done a phenomenal job. She and that team have done a phenomenal job, but we still have a gap. And I said it yesterday. We have 500 nursing vacancies over 29 counties. And we have 300 provider vacancies over those 29 counties.
Can you say that a little louder? I'm sorry, I'm having a little hard time hearing on this.
Sorry, I'm usually not quiet. We have 500 nursing vacancies over 29 counties.
This is at your organization?
At Ballot. Yes. It was 600 last year. We have reduced that delta by a little over 100 since June of last year, and that's with the international nurses. We've also worked with the local colleges to try to redirect when, especially the nursing side, when they graduate, to try to get them locally once they're in clinicals and so forth. Again, when they're coming out of college, they're looking for the dollar.
Yeah. Yeah.
And I'll just tell you, my telesitter, we just finally got a market adjustment. We're paying them $12 an hour.
Wow.
Because average salary in where we live is $38,000 a year. So rural healthcare, and I'm not the only rural healthcare that deals with this, is always going to be at a disadvantage to the rest of healthcare. So if we're trying to build a policy, we've got to somehow, and I don't know the right words here, but we've got to somehow give some kind of incentive or something over to rural healthcare to be able to compete, because we can't.
And the rural health transformation dollars are supposed to speak to that.
Yes.
But where, I'm not confident that, it's a bit of a shotgun, in my opinion, the way things are.
Well, and my concern is too, we talked yesterday, and if technology, from my standpoint and my lens, I think I can solve a lot of my gaps with humans with technology, AI and automation. I can take my 50 nurses that I have on my various teams and expand what they are responsible for if I can add in AI and automation. Okay. But from the discussion yesterday, if that's going to be regulated too much or regulated to the point the cost, it's not worth the benefit anymore, it's going to cost me more, then that's going to hurt rural healthcare, especially because I think with that rural health transformation grant, if we can get the appropriate dollars, we can actually automate and use AI to cover a lot of those gaps. At least that's my plan.
Can I jump in?
Yes, please.
I think, Marshall, I completely agree. I think we obviously need to show the basis of what's been done. And I apologize, I can't speak for the physicians or the PAs or anybody else. From a nursing standpoint, we've been talking about the nursing shortage forever. The National Academy of Medicine put out their Future of Nursing report. They do it every 10 years, and they're always calling it out. I think, interestingly, in support of the public health emergency, so that this international nurse conversation is a real problem. So we just got back from the conference of the International Council of Nurses, and they're talking about the nursing shortage all over the world. In fact, the ICN, this is actually on the AACN, who I don't know if AACN is here with us today, has a really good sheet on the nursing shortage.
No, they're not.
Okay, the ICN themselves put out a report in 2023 talking about the international nursing and called for it to be specifically a global health emergency. So when we take nurses from other countries, we are literally doing the
Yeah, we're robbing Peter to pay Paul.
Thank you. That's exactly what I was looking for. Peter to pay Paul. And in the United States, we're seeing it everywhere, right? We have states that have the worst nursing shortages. The rest of the country is subsidizing their nursing workforce through travel nursing, which is horrible for those states, because then we're seeing hospitals close because they can't afford the costs of it, right? Our reports show that one travel nurse may cost upwards of 4 times the cost of one local staff nurse.
We had to close units because we can't afford it.
Can't afford
either
it.
Close the hospital or close units.
Yeah, my first job at a hospital as a nurse many years ago, teeny tiny rural's not even the word. It was still designated as frontier medicine. So far out. I didn't know that was a thing. We had 14 beds, in the whole hospital, and the nearest cardiologist was a 12-hour round trip. Right. So what does that mean? It means people don't see the cardiologist. They don't go. Right. When I signed on as a staff nurse, 2/3 of our nurses were travel nurses. I mean, you talk about the damage to healthcare, and that there's just no continuity of care when your nurses are shifting every 3 months on different schedules. Right. All of our providers in-house, we were bringing them in on 2-week shifts. They'd come and live and then move, and then come and live and then move. That was very difficult on them. So I think all of that, to Marshall's point, I think we ought to, for sure, make sure that HHS knows, look, we have done this. We need some help. Like we have done this. All of the healthcare professions, all of the provider professions are struggling. From nursing alone, every single year we turn away tens of thousands of qualified applications to nursing school. We cannot create more nurses unless they go through nursing school. We are the keepers of the pipeline, right? Medical school, PA school, you name it. You can't create more unless they're educated. So we need help on our side of things. And then once they get into the profession, from a nursing standpoint, 33% of all new nurses, 33% leave the profession entirely in the first 2 years after graduating, because the environment's so bad. They graduate from school. We can own that schools aren't preparing them adequately because of regulations put on schools. We're graduating test takers, not nurses. Then they get into the profession and go, wow, this is hard. That first baby that comes out not breathing.
Yeah.
And they go,
And
I
there's
can
a
handle
high
it.
disrespect now for the front line. I mean, violence to
Oh my
the
goodness.
front line, especially in our area, has significantly increased since COVID. So is there a way that, this is my simple mind here, is there a way that we could make the healthcare professions more glamorous again? Because it used to be glamorous, for lack of better words, to be a doctor, to be a nurse, to help people, but something has happened since COVID to where
Oh yeah.
no
Yeah,
one wants to
absolutely.
be there.
I don't know if those kids who know who Dr. David Auerbach is. Published a paper in Health Affairs that from 2020 to 2021, we lost over 100,000 nurses, and most of them were under the age of 35.
Wow.
How do you continue? And that's just nurses. Right? I don't have any data for anybody else. I have no idea how many physicians, how many physician associates. I don't know if this even includes NPs, PTs.
Like,
okay, I
what
don't
are
know.
those people doing after they leave though? Like, what is their next step? I mean,
Yeah.
if you spend 2 years going to nursing school and then you say this sucks, I'm not going to do it. What are they working at Walmart? Like, what is
Totally. Yeah, change professions completely.
what are they doing? Do we have any data on like?
I don't know. No, that's a good question. I don't know where they go,
Yeah.
but we know that they have left the profession. Like literally, they're not renewing their licenses, not just getting another job. Oh, I don't like this nursing home. I'm going to go into dialysis. I'm done. I don't want to be a nurse. You just spent all that time, all those student loan debts,
Right.
to be a nurse. And within the first 2 years, they're out 33%. We can't meet the demand as it is. From a nursing education standpoint, we are not graduating enough nurses to meet the current demand. And then when you take a third of those graduates and they leave, and then you have things like a pandemic and we lose 100,000. Yeah, boy, the data is all there. I think this is why even the ICN is saying this is a global health emergency. I think that's the message for sure,
We need
which
to
I
see
know
if we
Chris is
can
already
get the
saying.
data on what other professions are they going into.
That would be really fascinating. Yeah.
I know that we have the Academy of Nutrition and Dietetics on the phone, and some of the struggles in the RD community are a little different than that of some of these other licensure groups. I'd love to hear your perspectives. I know Charla's not on right now, but she and I did talk about this larger issue of there's not enough RDs, and so now there's the insertion of wellness coaches into areas that are very much outside of a wellness coach's scope that could potentially be providing patient harm.
Yeah, so I think, we echo some of the things that Marshall and others have said, and I think we have a real concern about unintended consequences in terms of, if we decide to move forward with a declaration of like, this is a public emergency, wanting to make sure that it's clear that we're not lowering standards in order to try to fix this problem or increase the pipeline, that there is an appropriate standard to the level of care, to what a qualified provider is. And I think, Marshall kind of like hinted at this when, he was talking about, sort of making sure that it is about, licensing boards and licensing the practice of medicine, sort of the same thing. There is a standard to the quality of care that dietitians provide, and to the level of what you need to do in terms of your education and your expertise to be a dietitian. And we don't want there to be this unintended consequences of we are somehow lowering that in order to try to find a solution or a workaround for this problem. There aren't enough dietitians out there. We get messages from members all the time in the rural healthcare setting, in the clinical setting. They can't find a dietitian. Unfortunately, for things like diagnosing or identifying malnutrition, assessing malnutrition, that is a hands-on physical exam. The technology isn't there for us to be able to do that virtually or remote. So we do, have that kind of hiccup with digital care. And then, yes, we do have maybe individuals that don't have the same level of training, then, coming in and being used in sort of that virtual capacity, because they can't find a dietitian. So I think that is probably our biggest concern with this, is just wanting to make sure that if we do move forward, it is very clear that there is like a standard of care that does need to be maintained, and we're not trying to find a shortcut around that.
100%.
And the other thing I'll add to that is we often do work. You mentioned health coaches. This is Kelly at the Academy too. We often do work with health coaches in partnership, but as Kim mentioned, they don't have the training that we have. It's very different.
Kim and Kelly, I'm glad that you mentioned that, Kelly, about health coaches. It's just a different type of scope that they have, and it's not to be replaced because the training is very different. And Kim, that's,
Is there any training with health coaches?
Yeah.
there is.
It's
training,
not
but it's not
there is
equivalent.
training.
I'm a health coach.
Yeah.
You are?
Congratulations.
Yeah,
I know
there
that.
is
Yeah,
training
thank
for
you.
health
Yeah.
coaches,
What can I do?
and there's
But it's not required training though. Like anyone can
Really?
be a health coach. It's
Right.
not required.
Oh.
There's no license or certification. I mean, there
There
might be a
is.
certification, but it's not mandatory to.
It's not
Yeah,
clinical.
it's not a mandatory.
I thought there is a board though,
I mean-
right? There is one board.
well, Kim
that
can
is
comment on that
So
and give the
there-
details.
Yeah, go ahead.
Yeah, so there are a couple of like different entities out there where you can maybe get like a certification, but there is one, I think, board that you're referring to in terms of like health coaching, and they do have a very good like scope of practice. There is, you have to, kind of have this education. There is training, but not all health coaches go through that. And in our last comments to CMS, when they were asking about health coaching, we did point to that entity as like a good entity for CMS to look at in terms of like, what could qualifications be, like what could scope be. Like Kelly said, we want to be very clear. Like there is definitely a place and a role for health coaching within the healthcare continuum. But right now it's a little bit of like the Wild West because there isn't necessarily licensing. There isn't like a standard of what exactly that means. We do have the National Health Coaching Wellness Board that is one entity that's trying to do that, but it's not standard. It's not standard in the way that your education and credentialing for like an MD, a dietitian, a PT, for example, would be.
And they certainly don't do what a dietitian does, which is medical nutrition therapy and a whole bunch of other things that we've been trained to do. But to give just one like real life example, and it's nice to know that we have a coach in the room and you may be familiar, like the Y. They work with a lot of community health workers and also coaches, but then they tend to have dietitians who may be managing those programs or managing those folks.
Go ahead.
And I know
This is purely anecdotal, but I think it's somewhat illustrative of the problem. I have at least 2 physician clients who have given up the practice of medicine to be health coaches. These people are so fed up with all of the soul-crushing non-clinical services that doctors are required to render these days that they have basically said, take this job and shove it. And they are now coaches. So why do I mention that? Well, not to suggest that most coaches have that kind of background. I don't think they do. But rather because I suspect, and I don't denigrate the value of compacts in the slightest, that there are more fundamental problems that account for the fact that not everybody who has the brains, the diligence, the skills, the character necessary to provide healthcare is going to be attracted to the field in the first place because of the way we have saddled all these folks with jobs that do not involve actual provision of care. And because those who do, in fact, go through all the rigors of education, training, takes place over years and years, as Blake has pointed out, abandon ship after a certain period of time. So a question that it comes to my mind, I never thought about it until just now. Has anybody looked? I understand from this conversation that this is not peculiar to the United States. We have this problem in many countries around the world. Has anybody attempted to look on a worldwide basis at other countries that face this problem? Which ones are comparatively well off, relatively well served, have relatively large numbers of providers per unit population versus those that don't? And if there are such differences, has anybody tried to figure out why? Is there anything that country X is doing that we're not, or country Y is doing, that's maybe somewhat better than what we're doing? Flip side, is there something that country Z is doing that's even worse than what we're doing, so that we can know what to avoid? If this is such a worldwide problem, it might lend itself to some sort of comparative analysis that would allow us to at least maybe find some common denominators about factors that are aggravating this problem, so that we might get some guidance on how to avoid them.
If I could just jump on that too, because I think one of the as I'm writing my notes too and thinking about this, but maybe that's the ask. If we do this, if there is a declaration of a public health emergency, is that we ask the Department of Health and Human Services to perform or form study groups that look at regional look in the federal regions and say, here are some success stories and here are some failures. Include a global search. That makes a lot of sense too. But the ask is that as a part of this emergency, that the federal government take a lead in finding options, and then those options be published and shared. So the state of Washington has, since there are so many of you here, has this great approach, and they've found a unique way to do this, or this hospital system in Georgia has found a way to do this, and that be the ask, that you provide then the professions the results of the study or whatever. And I think to the point of the dietitians, I think they should also do a review, so I'm acting like I'm in charge of this, but looking at licensed, regulated professions, but also looking at those unlicensed or other, I don't know the term for them, but looking at those, the licensed professions and those professions that provide care that aren't licensed or regulated to the same degree. Because maybe that is the solution is, you have, I know that a lot of the rural, several of the rural hospitals that have used our physician compact really are using it to get the physician who can then supervise the staff and the nursing and the other professionals that are actually doing the hands-on care. So maybe the same thing could apply, or that could be, I don't know. I'm just talking out loud.
Yeah, no, that's a great point, Marshall. I mean, I think our objective here is not necessarily to figure out how do we bridge the gap, but what do we want HHS to do, the HHS coalition? Is it just pure money? Is it, education to other stakeholders? Is it a change in regulation, right? Like which of those are probably the three options I could think of that they would have within their purview. But what of those options or combination of those options would we think would be best to facilitate their solution of this gap?
Right. And finding one solution has never been the solution. But in a sense, if they could show these centers of excellence or centers of
right.
Whatever.
I mean, like I've never heard of that, build out a church, and family and bring international nurses. Now to Blake's point, maybe that's not the best option in the world, although we're only worried about the United States. So, so what do we think? Is the challenge funding? Is the challenge nursing school regulation and physician regulation? What are the challenges that are actually blocking the adoption of more clinicians?
If I may, if I can, were you asking someone else, or can I just say something here?
Of course, Lisa May, go ahead. We can't hear you so great.
Sorry, I'm on my phone. Unfortunately, I'm not able to be on camera. So what I listening to everyone, and all very interesting points, and really sharing what the issues are. How we eat an elephant one bite at a time. And I think how we approach CMS is by showing what are the outcomes we're experiencing because of the shortage, and maybe work backwards and say, okay, this is an outcome that we're seeing, and maybe prioritize or rank which outcomes, and maybe geographical areas that we're seeing that we would like this public health emergency to specifically be able to address. And perhaps that will help us to formalize the approach, because the problems are wide and vast and multifaceted. And, you can take it from the schools to, the different disciplines and the challenges they're facing. But if we look from the outcomes and what are patients themselves experiencing as a result of the shortage, and then maybe from going from that, then looking at it's more prevalent in one area versus another, and then maybe working backwards, we can come up with really concrete and outline bullet points, so to speak, of what we would like this public health emergency to concretely address. Thank you.
So Lisa May, I
This is-
think you bring up a great point. I would like us so we have a limited amount of time today, so I want to reframe how we're going about putting together this essential work product, because this is a working conversation coalition. So we are not here at this moment in time to solve the clinical workforce shortage for RDs and MDs and nurses and PAs. That's way too complicated. Our goal, right, our sole goal and mission right now is to answer the question, do we want to suggest to HHS that they put forth a coalition? And what, if the answer to that is yes, collectively by the group, what does that coalition do? Do they conduct research? If so, what does that scope of research look like? And it could be 30,000 foot for right now, and then we could dig deeper on it. We want to be careful to not represent one specific group like nursing or MDs, because these issues are going to be very different, and we don't want to leave out a licensure group. I mean, I could see a situation where it's really easy that RDs are left out of the conversation or PAs are left out of the conversation very quickly, because we might have too focused on nursing or too focused on MDs. Go ahead, Tate.
Sorry for jumping in.
No, please, go ahead.
When I was here a couple of months ago, I mentioned that when you look at the public health emergencies that have existed in the past, the opioid one comes to mind in some ways as being nebulous and more like this. And it started off with a commission that did a report that was chaired by a Governor Christie from New Jersey. And it just strikes me when we look at the problems here, it's really not just a coalition of professions or types of businesses. It's really systematic and globally, if not at least a national problem that spans from communities and state regulation to public attitudes to licensure, credentialing, to just a whole host of things. And it strikes me that this is a model where you would really having some kind of commission to study things that really represented not just professions, but a very broad stakeholder group. And, you know, like you would probably want to include not just HHS, but representatives from across the federal government, as well as state governments. And then
there is an organization
Really-
that does that, CLEAR, the Council for Licensure Enforcement and Regulation. They're an international organization, and they're not specific to medicine. They're all licensed professions, and they have, I'm part of their international relations committee. They meet monthly. There's tons of committees. They go over lots of issues, and I'm sure they have a lot of this data. And then in collaboration with them, they've been around for a long time.
That's awesome. Let's include them. in
Could
the conversation.
absolutely be part of
Spell that out again.
CLEAR, Council for Licensure Enforcement and Regulation.
Thank you.
And I
Can I
spoke at a
jump
couple
in
of
here?
events, right? Is that the same one?
Hey, this is Kelly from the Academy. I just want to go back to what Lisa May said, and I 100% agree with her. We need to know where we're headed in order to start this. And from my perspective, my team will tell you, I always look at what's the unintended consequences. And what I hear in the discussion is that potentially an unintended consequences for many professions is that there would be deregulation, and that we would have more people out there practicing who are not trained. So and we have had people who have died because of malpractice or somebody not practicing to the scope that the person thought they had. And we need to avoid that. So I guess from my perspective, and then also the other thing I would add is if we're declaring or wanting to declare a public health emergency, to what end? What's the measure that health emergency has ended?
Very good question, Kelly. So two things that I want to address is that we are already dealing with the impact of the clinical workforce shortage. We have, some would argue, for several decades. So the fact that we declare it doesn't change the status of what patients are experiencing right now. Many would argue that many patients are receiving lesser quality of care because they can't access providers. Advocate has an 800-bed hospital in Georgia. They could only fill 300 beds because they can't fill it with enough nurses and other clinical providers. Kaiser Permanente is shutting down, not essentially shutting down, but limiting their providers to utilize digital health services. So if they have the choice between digital health or in-clinic care, usually these providers will choose digital health. They're saying, no, you have to come in clinic because the problem is too big. My point in highlighting that is, yes, the shortage already exists and quality of care is likely already being compromised. But what we want to do right now is make sure that, and CTeL's always had this position, those that have been with CTeL for a long time, specifically as it applies to telehealth, we do not want a lesser standard of care because it's happening virtually, nor do we already have patients that are suffering because of not enough people being able to help. So we don't want anything else that could create a lesser standard of care for patients, many of whom are in underserved urban and rural areas that are already not getting great care.
Sure.
So I agree with you 100%.
So I'm a little bit confused because you said at the beginning that CTeL doesn't advocate. So I guess for us, like, are you asking us, the group, if you want to do research, or it sounds like maybe there's already an agenda that you want to advocate for this. So I just want to be really clear, like, where's the starting line here for this discussion? And maybe I'm misunderstanding.
So the CTeL is a research institution. So when when CTeL does research, or there is research that we're made aware of, then we provide that information to HHS or to other policy, those that have jurisdiction over that policy issue. We were presented with research that showed there's a clinical workforce shortage, and that clinical workforce shortage is negatively impacting patients' access to digital health because there's not enough providers to actually staff these digital health units. And that bridge that was typically used is probably not available to some of the most underserved patient populations, and that's concerning to CTeL. That was the research that we were presented with. So when we brought that to HHS said, great, what do we do from here? Do you want a waiver? Do you want funding? What do you want, CTeL? And we said, hold up, we need to ask everybody else because we can't represent everyone else. After several conversations, and the conversation I think that we're landing on right now is, it's very serious when you declare a public health emergency because you're saying, we don't have enough providers. And getting back to your point, that's a known. That's been, data shows that, HRSA says that. But public health emergencies are temporary. Now, the opioid public health emergency has been going on since 2017. Okay, so, what is the end? I don't know. I'm working with a secretary of HHS from a different state who suggested that they would like to partner with us on this as a pilot in their state, but they don't want to declare it as a PHE. They want to declare it as a public health crisis, and they want to create their own state coalition to conduct research. But they've been working on this essentially separate and adjacent to what CTeL's been working on for several years now. So maybe we call it a public health crisis. I'm going to look to others that have more policy experience. Tate has a lot of policy experience in this area. What are your thoughts here? Because I think we need to begin with a point of research. We need to have all the parties at the table, have different agencies at the table, and conduct and have it as a conversation point.
Yeah, I'm just stepping back. I think research is very important, but it is so broad and so nebulous. It's kind of hard to know where to start and where to end.
Okay.
In a lot, I'm take to jump back, but in a lot of ways, I think when Congress passed the Affordable Care Act, there was an expansion of coverage, but everyone knew that unless there were providers, it didn't matter.
Right.
And one of the most uniformly bipartisan supported parts of the ACA was having a workforce commission to look and see how to address it. And I just think at the research, but stepping back at the larger question, I think a lot of us in the healthcare professions, are watching what's going on at ACIP under HHS, what is happening where other public health emergency or public emergencies, emergency powers are being declared. And it's just a lot of things. When Rachel was here with the colleges of nursing last time, they had a lot of concerns with Title VIII funding, what might happen if there's a public health emergency. So part of me just thinks building more consensus on the outside or maybe working with states. I apologize. I'm not like having a clear answer here, but this is a very vast and challenging problem.
I just want to add one comment here. I think there is one point that we haven't discussed so far is we have thousands of foreign medical graduates fully trained in United States, already naturalized, and they're available. I have a first-hand experience, by the way. I was not thinking to talk in this subject because it's not artificial intelligence related, but my wife, she's a gynecologist. We came to US 15 years ago. She applied every year, paying all the money, all the things to ECFMG. She's certified. She's a doctor. She cleared all the exams in first 3 steps. There are steps. We pay every year $6,000-7,000 to apply as a foreign medical graduate. She never got any call. This year, because of this shortage, she got a couple of calls. She has been working with me in the startup for last 4 years. Now she is a AI plus medicine physician. Now she got a calls. Now she has some interview set up. But I think there is huge availability of this workforce, and this is a very high ROI policy. If there is anyone can look into that, and this can be one of the agenda that you're saying. If we can do a little research, what is the workforce available? And there is no data available because people come and they get from the foreign citizenship, like they come from the foreign countries and then they become naturalized, and they are not. There's no data available, like what's the workforce we have. And they have fully trained, like my wife, for example, she was a gold medalist in C-section.
Mhm.
There's no data available, like how many foreign graduates we have. They're readily available, but barrier to entry is extremely tough. They're even completely neglected from the workforce. So I just wanted to have this point, and this is true for nursing, for MDs, for other medical professions. Just a quick point.
Thank you, Iles. Kelly, I just wanted to make sure that we address that appropriate. Well, I want to make sure that you feel satisfied with the answer if you have additional questions, because
I don't.
Okay. Are we on
Thank
the same page? Do you, or are we?
Yeah, I just have
didn't want it to look
concerns.
like CTeL's advocating for something.
No. We're in a situation right now where nutrition is a huge national conversation, which is really important. We also have a shortage of dietitians being able to provide care, but we have folks out there with inconsistent training. So I am concerned that we do not want a loosening of what, you go to a provider and you get less care or inappropriate care. And we're in a situation right now where I'm excited that CMS and HHS are looking at all different possibilities, but that could be the possibility that folks who really don't know what they're talking about start providing care. So that I'm just being real blunt.
Yeah,
so
that's totally
I want to be
fair.
really
I don't think
careful with this.
I don't think that's on the table. I mean, again, I think we've heard from the regulatory bodies here that, their licensing standards are certainly going to remain intact. And I don't think one of the things on the table is to simply just move down the licensing standards and say, hey, if you want to do this, go ahead and do this. So, I mean, theoretically, that is a possibility. So I agree with your point, Kelly, that someone who's not thinking about this could be like, well, why don't we have Jake become a doctor? That sounds like a great idea. It would be a great idea, by the way, obviously. But no, I mean, I think that's a fair point, and we just need to make sure that that's not on the table, because I don't think anyone here believes that is an appropriate solution at this point.
I don't think that's.
Then we're completely aligned.
Yeah.
Okay, and also, at a federal, we don't have jurisdiction over state licensure bodies. So I want to be like really clear on that as well. At a federal level, we are asking federal agencies to assess this and then use this as a tool for state policy, state policy adjustments, or addressing these issues at a state level. So to go back to Title VIII, we wouldn't have I think one of the attorneys that spoke last time, Hannah Bornstein from Nixon, said that would be a non-issue because it's a federal PHE. We wouldn't have to worry about Title VIII funding or the diluting of successes that many of these different licensing bodies have made.
Here's one of the issues that I want to bring up, though. I mean, you mentioned HRSA, and I was thinking about HRSA as well. They have a process for designating shortages.
Mhm.
So to your point, this has existed for years and years and years. Now
Yeah.
they have geographic shortages, they have facility specific shortages, they have
Yeah.
population specific shortages. Their entire job is to say that this is a problem. Are they as an agency simply failing? And do we have to be careful about that? And then I guess to your point, Tate, I mean, there was a workforce commissioned 13, 15 years ago, right?
Never got formed or funded.
And never got formed or
Correct.
funded. Okay, so that one has not happened yet, right? But HRSA this is HRSA's job, right?
Well, that's what I was kind of getting at to.
Am I wrong? I don't know.
No, I mean, go ahead, Tate.
HRSA's job is to address the workforce, but they designate health provider shortage areas. I think it was the first George Bush administration that really sought to reform how those are designated. There's a lot of incentives because if you're designated, and by the way, they don't count if a PA or an NP is practicing in a HIPSA, is that contributing to care? And we would like to kind of ask that we be counted, but guess what? If we get counted, a bunch of the HIPSAs that are designated go away. It's tied
They
to
lose the
funding. So
funding.
it's just it's just bogged down
Morass,
and a morass that's impossible to change.
Yeah. Interesting. But I think that's one of the big issues that you would need to confront with this coalition is that there's an agency whose job already exists in this exact area. And if there is funding related to it, you can see there's a lot of different constituencies that are thinking about this in a lot of different ways.
Right. I mean,
You know,
the fact that, HRSA knows in its published data that we are in a bad place in terms of clinical shortages and that we don't have enough providers right now to care for the patients we have. And it's going to get a lot worse in 20 years because of all sorts of socioeconomic factors that are dealing with patient care. So, I mean, after marinating on this over the last month, it would be neat to be able to have we asked them to fund a coalition on this topic, an interagency coalition to address the clinical workforce shortage, bringing together, of course, have representation from the licensure groups, but hopefully it's representation that is also academic in nature, where.
are you contemplating a state and federal partnership then?
I was
If they're
thinking.
licensing groups, then that would require state involvement.
I meant like AMA, ANA. I just meant those representing license. But I mean, there could be a state federal partnership. I could see that too. But that's the goal right now, is to decide what are we putting that suggestion forward. What does that look like?
I love the idea of a coalition. I think if we can even look at whatever this coalition was that was created and never funded. So many of the numbers that I quote regularly are HRSA numbers. It almost seems like that's where they draw the line, is they report numbers. And they're not doing anything else about it. It's just, oh yeah, here's another number that says it's bad. And then they just stop the conversation. If there's already a provision somewhere that says, hey, there's this coalition that should be created to discuss this, I think that's a great thing. Maybe
Well, who do we think should be, if there was a coalition, who would be in it, right? Because I'm thinking we have HRSA, right? Is it something like an FSMB? Is it the ILMC?
Interstate Medical Licensure.
IMLC? I can never do that, right? Like what are the federal and state and third party organizations that make sense to be part of that? Like, probably I mean, Micah, you could do it, but should it be FSMB instead?
Probably that.
Yeah.
But there's one thing I'm gonna ask, because I'm hearing what everyone's saying, and I agree that the coalition is the right path. But are we saying that this coalition is to study the issue? I think we're pretty clear on what the issues are. Or is this coalition to recommend solutions that will be meaningful? I'm just not hearing. I'm not clear on what.
I think we have to leave it up to them to ultimately decide what they're doing. I mean, I think to your point, they already have a lot of research on this, right? I think we want to have them come up with solutions. We can goad them in certain directions, but I think they have to come up with the solutions.
And I think part of that too, though, is finding success stories where states or regions or facilities or professions have been able to address some of that and then coming up with those. I think one of the other ideas too is looking at what potential pools of resources are out there. Everybody talks a lot about these foreign, with quotes around that, the trained professionals. Well, I would say, and this is just me talking, not my organization, and I'm not representing them in this, but part of the problem with that is that there's this unknown. Sure, they have all this training, sure they have all this, but who can certify that this foreign trained person can practice in the United States to the standards of the United States? There isn't anybody, yeah. And not even equivalent education, but somebody that could certify that they've met the criteria or they can perform it. I remember long ago and far away when I was working at the Colorado Department of Public Health and Environment doing EMS licensure. There was a big issue about, well, can you take a military medic and put them into an ambulance in a civilian hospital because they're trained two different ways? And what is the way? And CDPHE came up with a way of saying, as long as they can check these boxes and we have this so that's a long, I'm sorry, I'm rambling, but I think this organization or this coalition, finding success stories, being able to share and publish those, and then also making recommendations of how do we access pools of potential providers and provide and do it in a safe way within the regulatory confines and structures that we have. But
Is there not a education bottleneck for, you mentioned it, for nurses? I know that there is one for physicians and, other professions. Is that a place where we're really saying that's the pinch point? We really cannot even educate, like we're at the start. We can't educate enough people.
I think yes, and from our standpoint, right, from education standpoint, and nursing is a little bit different than most licensed professions in that nursing boards regulate nursing education. That's very unique.
Mm-hmm.
Most education is not regulated by the licensing board; it's regulated by boards of education. That's what they do, right? So we're a little unique. So there are definitely regulations that are hindering access, that are decreasing access to nursing education. And that needs to be addressed. And then also on the flip side of it, there's all the things that Joe was talking about is once people get into these professions, the culture's so bad, the workforce and the workload is so bad they want to leave. So we almost have to attack it from both ends.
Yeah,
I
totally
get more in and keep the ones we got.
I get the burnout and thinking about, one of the things that you said yesterday, Krista, around kind of making it, MAHA friendly. Are we talking about looking at, this is a deregulation? Here's a regulation that actually prevents us from educating more clinicians, which is exacerbating the problem, knowing that's not the only solution, but one of them. And this is a deregulation point that they might be favorable to.
A point here in the Washington state, there is a bill that any foreign licensed person can work under supervision. That is already passed. And there's a couple of other states. That's what I know about that because that's I wrote it. Oh, you wrote it?
The floor is yours.
No, it's not. No, so I'll struggle through this. Yeah, pipeline is the problem. I think it's the first problem we have to solve. To your point, unintended consequences, my worry is if we put something forward about that, we are going to see and this is happening in the International Medical Graduate Committee too, a call for ACGME to be supplanted and not be the only accreditor for residencies. I feel pretty strongly that that's a bad move, simply because when you're introducing competition in a place where you're trying to have clear standards for training, it's a race to the bottom. And that's absolutely not what we need. We've already got time limits and hour limits per week. We already have enough stress on the system. I mean, there's a bill that got reintroduced again, 14,000 residency slots for GME. We need to fix that. And I will fully say that is a profession-led problem. They created it in the 80s and exacerbated it in the 90s, and it got locked in. So that's part of the issue. But to your point, yes, there are ways to evaluate IMGs. We're not robbing Peter to pay Paul. They're here. So whether they're being a medical navigator or driving Uber, they're here. They can be brought in. I think that's one thing that we can absolutely face. It's like use the sources we have now. Ask that in addition to the coalition, because it's not about. We know that there's shortage, right? But one question that I never hear answered is, what is the appropriate level of physician assistant NP RN to a certain population and a certain population center? So we're trying to, in Washington State, trying to get the data that says if you reach a critical mass, you can support this many GME slots. And we don't have that data. I've never seen it.
That's a good point.
Interesting.
And also we create pathways for IMGs to get licensure that maintain their credibility, that they are capable of being medical professionals in our state. And then there's no residency positions for them, and they're never offered one. Even when we offer them financial benefit from the state, they still do not get positions. So even though we as a state have said they're good, they can practice, they can fill important gaps in our state and work, the residency programs will not accept them.
To add on to that, we've actually got a bill that is trying to get state level funding for IMG dedicated residency positions so we can have the both and solution. The other piece is there's going to be a push to have a pilot project to have these people that are working under clinical supervision work for a certain number of years and then become fully licensed. This is something that's going on in Canada. Nova Scotia just launched a pretty large model about that. It seems to be working. And I think, Blake, to your point, as you were talking about that really kind of made me think, I don't think it needs to be part of the PHE to deal with that, the culture. I don't see how a PHE is going to do that. But to your point, those 33%, I think you can have them wash out earlier or have a better understanding if there's true preceptorship, apprenticeship type models for certain professions. And if you start them and they get all of their training in the hospital, then they're going to know up front what they're getting into.
Yeah, I think it would be, I appreciate it, Mike. This is fascinating. I think it'd be really interesting. So let's say if a coalition is created to discuss, because I don't know what the bottlenecks are in medical education, right? And create
slots.
Yeah, that's new to me. I've never heard that.
We've got enough medical schools and osteo schools are opening up.
It's just
they're training the same.
Residency. So I think that would be really fascinating to discuss all these, because like with the dietitians, I have no idea what the barriers are to entry into dietitians. Like what are the bottlenecks and how do we address those bottlenecks? Because that's fascinating to me. In nursing, we are robbing Peter to pay Paul. Like we are taking people right out of their country to help subsidize our shortage. These on top of those who are already here, trying to get them licensed. And then many of them come here and they're sending their money back home for family. And I think that's great, but we're also hurting them according to the International Congress of Nursing. We don't want that. We want people to be nurses where they live, where they grew up, and be educated, work there and live there and support their families there. That's great. So that's for sure for us. But I have no idea what's going on with the dietitians. I don't know what your guys' bottlenecks are. I think it would be really great if we had some sort of a discussion that says, okay, what are the barriers to access here? This residency thing, I had no idea, right? That's not my purview. I do want to say, I have to give a shout out to our dietitian friends, Kim and Kelly. You guys have the best digital background. It's like a bright, happy spot this morning in cold DC. So thank you.
We'll have to tell our comms team about that. But
yes.
And I know that is a whole other discussion, but just sort of like high level, in addition to not having enough dietitians, when they do get trained and they come out in the field, right now we are dealing with insurance providers deciding to reimburse for dietetics care lower than Medicare. But that, so then you have system, and Kim, I don't know if you want to add to that, but like there's a lot of payment reimbursement issues, and then whether or not this can be a viable income, and long-term sustainability for someone in their career is an issue that we're dealing with.
Wow.
Yeah, so I think that there's like two problems. You know, one is like most of the professions, like getting enough dietitians in the pipeline. And then the second piece of that is then, yeah, the sustainability of dietetics, like as a profession. You know, some of it is like workload. The other piece is like funding and payment. And like that piece, both, you know, when we're looking at, you know, Medicare and like cuts to rates, when we're looking at particularly in the digital health space, when we're looking at like side of service sort of like differential in payments and different things like that, that's a big piece of like sustainable payment and reimbursement. And then on top of that, when you look at loan cost and now, you know, what the government's doing with what professions are considered professional and what is the ability to be able to even obtain loans and make it through the education pipeline. I think, you know, we have to look at it from two angles. How do we fix the pipeline issue in the beginning? And then how do we maintain our providers from burnout and make it so you can be a sustainable provider long term? And I think, you know, I think Lisa May was, you know, kind of said it earlier, this is a multifaceted problem. So whoever we're going to recommend, what entities we're going to recommend to be on this coalition, I think has to address all of those. And I don't think like adequate payment and funding challenges is like unique to dietitians. I don't think, I think that would cross over into many of the other professions as well. So I think we need to be able to look at all of these pieces and who are the players, not only from federal and state agencies, but also industry that can help alleviate some of these burdens. And then the last thing I'll say is on that like deregulatory piece, you know, we don't want it to be a race to the bottom, which we've all agreed, like, no. But I think in terms of what Marshall or somebody was talking about earlier, in terms of like physicians and whoever leaving because of the administrative burden, what are those pain points in terms of administrative burden that might be able to be alleviated to make the burnout less, to make the professions more sustainable? And so thinking about entities that can assist with that and the evaluation and alleviation of that.
Yeah, agreed.
So it sounds like, because I want to be cognizant of time, we have one more hour for this discussion. Does anyone want to take a 5 to 10 minute restroom break and come back, or are we good? Welcome back, everyone. So we have about 40-ish minutes until our next session. So let's do a quick recap. I just need kind of where everyone's thoughts are on our process and steps moving forward. We would like to request that to HHS that they put together an interagency federal and state coalition / commission. We have to look up the wording choice there, led by HHS to address the clinical workforce shortage. While on break, Tate and I looked at the ACA commission that was commissioned in 2010 that was unfunded. There's a couple PubMed articles that were published on that coalition. I encourage you to take a look, and I could, Lydia, I could send it to you if you could put it in the chat. Sorry, excuse me. What Lisa May said is that all clinical providers have essentially the same issue. How do we fix the pipeline issue? How do we fix pipeline issue and maintain providers long term? So it's how do we get those interested in becoming a clinical provider, and then how do we maintain their interest in staying a clinical provider? That's number one. Number two is professional payment challenges. Everyone that we have talked to, RDs, nurses, PAs, physicians, all have expressed professional payment challenges, which have led to retention issues. And then academic funding challenges, specifically surrounding payment of their education. and loan repayment, once that education is completed. So the question then is do we agree on those essential three universal issues?
Do you want to wade into the payment of education issue, given that it does have a little bit of a muddy space right now?
Like the professional degree designation.
They're intentionally trying to lower the.
Yeah.
Do you want to weigh in and muddy that water?
I don't think we do.
Which is because that's a Department of Education, right?
Yeah.
And
Stay
I
away
think,
from it.
yeah. And there's
I'm
gonna
not
be
saying it's
more
not valid, of
discussion.
course.
Yeah.
We've got a
There's gonna be a
frontliner
lot more
right here. What are your thoughts,
Yeah.
Soldier?
How about professional compensation and regulatory issues? Because I do feel like it's broader than just payment, and it's being able to make a living providing the care that people need.
Yes.
So are you saying that we remove the educational issue
No,
or?
to take payment and put compensation and regulatory.
So professional payment challenges and just leave it at that?
I would say regulatory challenges too, like that, which kind of can't get at payment and can get at other things.
That there's this other capping of professionals too, so and that's a regulatory.
Yeah, well, you got the regulatory licensure boards, you've got the proprietary education departments, and they're never the twain shall meet. I mean, I've been in some legal controversies where they don't talk to each other, and you would think they would.
Amen to that.
So just to be clear, pipeline and maintaining of clinical workforce staff. Number one, professional payment and regulatory challenges for retention. And then we're Xing out academic funding challenges because we're going to use less controversial language. Is that right, Tate?
Get rid of what that's more.
Oh, is it being suggested that we remove academic funding challenges because, or keep it?
Can you read the three again? Well, I'm sorry.
Lydia,
one
can
more
you put these on the board? Can we do a share screen? Because I can't actually get in.
I thought she was wanting to change reimbursement.
Not
No, it was-
reimbursement.
okay.
I was saying, do you want to wade into the education
Right.
space because there's muddiness around what they're trying to do around the Department of Education?
So it's
And I've
pipeline
actually
and
been-
retention.
And I've actually been hoping that HHS would be a favorable force on the Department of Education. I don't,
Yeah.
Yeah.
maybe that's
I do
lost
think
hope.
I do think your change to the reimbursement question was a good change to also.
Okay, so number one is pipeline and retention.
Okay.
Number two is professional payment and regulatory challenges. And number three is academic funding challenges. The question is do we want to remove number three?
And I would argue academic funding would be under pipeline, would.
Yeah.
Yeah.
Okay,
That's
Because of the kind-
okay. I thought I heard something different.
okay, so, but do we want to put it as a sub bullet under the pipeline? Or do we just
I
want
think
to?
so.
Okay.
Yeah. I don't definitely don't want to remove academic funding. I think it's academic access, right? It's access to,
Yeah.
Oh,
There
I
you
like
go.
that better. Academic access.
yeah. Because whatever that there are social determinants to access, there's funding determinants to access. So
I think, and I would also add the other part to that, to Micah's comment, that so it's not just the academic, but it's also the professional training.
yeah. So is that's a
Oh.
separate
Okay.
thing.
Yeah,
Okay.
but both of those being part of the pipeline.
Agreed. Agreed. So pipeline really is the right word.
Yes.
Agreed.
So maybe what we do is pipeline is number one and retention is number two, because under retention could be payment. So it sounds like we have a pipeline and retention issue, and those are the two main issues.
Yeah,
So
I think
pipeline and then retention. And this is simple way that the simpler we make it, we have these like catchphrases. Well, it'll
Yeah.
get grabbed onto quicker. So we've got a pipeline issue. Those include academic access and professional training. Within academic access includes social determinants of health and funding.
I think the regulation is beyond just payment though, and because it's also like telehealth, license portability, a lot of different I think regulation needs to be in somewhere.
I agree.
So do we could put regulation within retention probably.
Well, it's
kind of
Or
pipeline.
maybe it's actually its own.
It
Yeah.
fits both, right? There
I need
are
a better word
regulations
for
that are
regulation because they're not
decreasing
gonna like
access,
that.
and there are regulations that are kicking people out. Like it's a big one.
There's something you could like lump burnout and like practice.
That's under
type thing.
retention.
I think that's retention.
Yeah, that's retention.
Yeah.
Not sure what they could do with regulation other than identify issues within, because it is down to the states.
Absolutely.
Yeah.
So I don't know.
I mean, some's federal and some state and
Yeah.
some,
Yeah.
like the GME stuff is largely federal.
Right.
And then
Yeah,
RD
totally
said that
agree.
there's
Me with
funding.
a
Oh, that's
pipeline.
Mhm. I think coming from a federal level would be great to hear them say, hey, a big part is state regulations is the problem.
And you need some state representatives in the commission
Yeah,
too. So
like having you guys on this kind of a coalition or commission would be phenomenal. People who are the experts at the state level. Same thing from a nursing standpoint, from an RD standpoint, from an MD, DO, PA, all of that would be really
That
good.
being said, we are here, and I'm not saying anything about any other states, but some other states, their regulatory boards are underpaid, understaffed, and are not on the same level and cannot communicate probably even their metrics.
That's true.
So that's
because it's how they're funded.
Yep.
Which is part of the problem.
Yeah.
Public Citizen actually, like a decade or so ago, came out with 10 things that make I guess, an effective regulatory board. And, you know, one of those obviously was a dedicated funding stream.
Yeah.
So you could use that as a starting point.
Nice.
dedicated funding stream was important to regulation.
Yeah.
I think and the Public Citizen came out with.
All right, pipeline retention regulation. I'd love to find another word outside of regulation because that's like a pejorative term in this administration, so.
Public protection. Was an
They
idea.
love the word deregulation, but I don't know if.
We'll stay away from that.
Yes, actually, to Kim and Kelly's point. Public protection, pipeline retention, and I like public protection.
Yeah, that's supposed to be what the end result is going to be.
Public protection or access to care.
Which is pipeline.
You need to
Oh,
balance
access to
public
care.
protection with other things.
Yeah.
Right, because just because you have access doesn't mean it's quality care. Like you could have access to Jake.
So why not do that as, you know, public protection and access?
Yeah,
True.
he's not in the room, so I could say that.
Yeah. Public protection and access.
All right, so it sounds like we have our three areas. I'd love to come up with some type of acronym or fun little branding thing that they could hang on to, but so far it's PRP, which for those in the derm world, that means something completely different. It's an aesthetic treatment. All right, then next up is let's talk about what, so we're going to say these are all clinical providers are dealing with this issue that impacts the clinical workforce shortage. So who do we want? We are suggesting to HHS that they fund a commission that would include state and federal and academic, state and federal agencies and academics. Of course, so let's talk about state because we've got good state representation here. Let's start doing it. I have NGA, National Governors Association, Federation of State Medical Boards, CLEAR, Interstate Medical Licensure Compact. We would also want the Nurse Compact.
CSG.
What is it?
CSG.
Yeah, well,
What is that?
Who's CSG?
well.
Council of
the
State
Council of
Governments.
Governments
Council of
promotes
State
a lot of,
I
a lot of
would
the
not.
licensure.
No.
I
Okay.
But they're getting out of that business, I think, because the Department of Defense has been funding a lot of it. And
I'm just gonna put the compacts, the clinical workforce
Yeah,
compacts, because I don't know all of them. RDs, do you have a compact, right? Are they online? Can they hear me?
Are we muted?
And they should.
no, they're seeking a compact to be
Okay.
enacted. I don't know where that stands.
But could those people hear? April, can you hear us?
I think they're off.
How about going broader, like licensure portability experts, because you have
There's many
professions.
pathways. Yeah.
So, okay, that would go under academics.
Would that not be HRSA then? Did they give out license portability grants and everything?
Lydia, is anybody
Yeah,
on?
well,
with
in
us
fact,
there?
they've
Can you
helped fund
kind of see
several
what's going on?
including IMLC. So
Some folks are muted, but the conversation kept going.
So they could hear us? Okay, they're not saying it. That's what I wanted. All right, so I don't think that's a comprehensive list. Who else? So we've got NGA, FSMD, nurse licensure compacts. I'm sorry, the compacts, and we'll have those represented, and our team will do some research to see who all has a compact. Rick, you and I probably have a.
We include the IMG Academy. What is Micah? What is it?
The International Medical Graduates Academy. They're
Okay, that sounds
they're based out of Washington, but they're national.
Is it the what is it?
The International Medical Graduates Academy. We can give you a contact for that if you want.
What do they do?
They represent IMGs and they focus on policy to make it accessible for IMGs to get licensure across the country.
I don't have a contact there, so
I'll get you Dr. Mohammed Khalif. I'll get you his information.
Perfect.
Yeah.
Okay.
the National Conference of State Legislatures.
Yeah.
NCSL.
Oh, national, yes, of course, National Council of State Legislatures. And we have a good contact there, but you probably have a more current one. Okay.
Probably large employers and payers.
Or is it Eric? Is that what you're thinking?
They would be from that community. But I mean, it could also be just a large employer themselves or a health plan or.
Oh, okay, you're saying just.
Like an HCA or even the VA, like somebody that.
Well, no, I also meant just like, 80% of private sector healthcare is funded by employer-sponsored coverage. That's definitely part of the system.
So are we thinking like AHIP?
I don't think it's our place to name.
I think they're going to want a suggestion list because we want to make this super easy for them. Like we're going to want to say, this is the suggestion list and this is the contact information.
Then I would say like AHIP and Eric would be.
Okay.
Like those,
Yeah, we have good
groups.
contacts with Eric.
How about the professional associations, AMA, ANA?
Yep.
Yeah.
I can't assume you already have AAMC. We're not there yet. We're going to head to the academics next. But thank you, whoever said that. I'll put it on here.
If you're putting the governors in, do you want the attorneys general too?
That's a very, thank you, Joe.
And most of them represent licensure boards, or many of them.
What is the name of their association?
NAG.
That's right.
National Association of
Not gonna
Aspiring
say,
Governors.
sounds like a pejorative.
Yes.
Not gonna say anything.
They must have some fun with that branding.
Oh, yeah. Well, we used to call them the National Association of Aspiring Governors.
Case in point in Washington.
That's funny.
Right, state insurance commissioners too, but we're getting pretty granular.
That's not a bad idea, though.
NAIC.
NAIC, yeah.
Acronym for AIC?
National Association of
Of Insurance Commissioners.
Insurance
Yeah,
Commissioners,
They head up all the insurers
Association.
or
So-
regulate them.
Question, Krista, and maybe this is for Marshall, Rick, Tate, and anybody else. So nursing, there's already a National Advisory Council for Nursing Education and Practice. That was created by, I don't know, HHS or probably we're gonna want to add them, right? So we're gonna ask HHS to create something that's already been created. Does anybody else do?
Well, the National Council of State Boards of Nursing are the regulators. That's all the state.
Yeah.
Yeah, I have them here under the state agency.
I mean, like from an actual federal level, like there's already a federally sponsored
Yeah,
committee
I'm familiar
for
with that
us. Is there anything with the medicine or
I'm not sure.
PAs that already exists.
Oh, how about NAM?
Oh, yeah, that's a
Yeah,
good
National
one.
Academy of Medicine. Because Congressman Costa was trying to create a nursing shortage task force. He had a bill that he's been running for years. And basically HHS came back to him and said, well, we already have this committee that we created. So does anybody else have a committee like that? Because we'd want to
There's-
probably be mindful of that.
There's the AAPA, the American Academy of Physician Associates.
Yeah, no, I'm not talking about
Yeah,
industry
they're right.
professions or industry associations. I mean,
Perfect.
like, is there, the NACNEP is a federally created advisory council that was created by Congress to advise Congress. Does anybody else, that's for nurses, does anybody else have one of those already?
I think so.
Okay.
For doctor
Okay.
medicine.
There's a yellow book.
MedPAC's the closest thing I can think of,
Oh,
that
that's
would
a
like exist to advise Congress.
Okay.
That seems pretty different, though.
I don't think they'd be like on a
Mm-mm.
on
They're,
their own commission.
they're
no.
neutral. They have
That's
to
all
be.
about reimbursement.
Telephonic case management
That's
nurses.
What did you say, David?
Advising
Auburn?
Congress and HHS, it's like. shit.
Yeah, okay. So it sounds like it's just this
Payment.
one.
Yeah.
advisory committee.
I
Okay,
guess it is a
good.
payment advisory committee, so yeah.
In interest of time, this is a good start. We have 30 minutes left before our next panel. So we will do what we hope to be a really thorough investigation, and we'll put some language in the memo or whatever document we ultimately land on to HHS saying that we'd encourage, we'd encourage them to also add to this list, of course. We'll send this off to those that are part of this conversation if you ultimately think of an entity that should be added. All right, let's move a little easier. Let's move on to federal. So we have HHS, CMS, HRSA, DOE, DOJ, DEE, DEA. Anyone else? We should also probably add Domestic Policy Council on there, even though they're not, they're technically an agency within the White House.
By DOE, you mean Department of Education,
Mhm.
not Department of Energy.
Yeah.
Just
You're right. They should change that acronym. One should have.
Maybe we should call it A1.
I mean, I guess the
No,
VA,
you did not.
I guess the Department of Veterans Affairs.
Hey, yes. All in favor.
This is why I love having you at meetings, right? You're my favorite.
I'm sorry, I couldn't resist.
Well played.
I need some humor. This stuff's dry. Okay, so we've got Department of Veterans Affairs, White House, Domestic Policy Council. Is there anybody else within White House that we would want to ask? Econ, maybe?
NEC, National Economic Council.
Hold on one
That's a
second.
good idea.
Is a counselor committee. I think
What is it?
it's NEC.
Oh, yeah.
So we would be saying,
National
this
Economic
is an
Council.
exhaustive list. This is just a selection of recommending, yeah.
HHS, CMS, we're missing someone. We have DOJ, DEA.
HRSA.
Yeah, we've got HRSA. HHS, within HHS, we have CMS and HRSA. We have Department of Education, then DOJ, DEA. We have Department of Veterans Affairs, then we have White House, Domestic Policy Council, and National Economic Council.
IHS.
That's a good one. Yeah.
What's AHA?
IHS.
No, AHA, the healthy America thing. They're and they're restructuring, they're creating.
You mean Indian Health Services,
Maybe
right?
I see, yeah.
We should
I
probably
forget what
also,
it was, but AHA was what it the
Yes, it
acronym was.
are there disability councils or those, I don't know if that's the correct terminology, but that should also probably be
Sure
included.
there are. I can't think of.
DOJ, you mentioned DOJ, they've already launched a task force.
That's right.
To investigate state level regulations that are barriers to license.
Oh,
professions.
FBI.
So it'd be good to maybe bring in that task force already.
Good luck.
So we would want,
Yeah.
David Alburn. Are you with us? FBI would probably,
Yes.
you have some relationships with associations that are dealing with interstate licensure issues and the conveyance of FBI data. What is that association's name?
I don't have the association name, but that matter that you bring up is has got a rogues gallery of people in there that that's my name for it. That when there's too much opposition, then you got to go see these people and kiss some rings.
This is a whole pocket rep list. All right. Do we need to involve? We don't want to involve any international bodies, correct? Because of the foreign licensing.
I wouldn't put
issues.
WHO on it.
No
No.
kidding.
Well, and it's a pretty good list already.
Okay.
Yeah.
Yeah.
In terms of academics, we'll do some research. We'll do a general lit review and see if we can name some noted academics in the space. But go ahead, Lydia.
OSTP was suggested in the
Thank
chat.
you. That's what I'm talking about. Group think that, or group OSTP.
Thank you. I'm still
Whoever
here.
said that, thank you.
It's Brooke.
Thank you, Brooke.
Yep.
Oh, do we want OMB or any of those that, no?
They'll be coordinating all the agencies.
Yeah.
Anyway.
Who else?
Well,
Who?
AAMC.
Yeah.
FTC?
Yeah.
Okay.
FTC also has a task force right now investigating state level regulatory issues that are FTC and DOJ are kind of doing the same thing.
They just wrote a letter to the American Bar Association.
Yeah.
about
Oh.
The lawyers. But I assume AMA has similar concerns. Antitrust.
What is the nursing equivalent of the AAMC?
What's the AAMC?
Association of American Medical Colleges.
AAC.
Yeah, they're going to be under academics.
Yeah.
How about, physical therapists have something like that? Do the psychologists have something like that?
Yeah. Some do it in-house in their like associations, and then some have their own education associations.
The Federation of State Boards of Physical Therapy, I think, has some responsibility for educational issues for PTs, but I mean.
You got dentistry.
Dentistry, yeah, there's a interesting contradiction. They've got two different compacts circulating that are in conflict with each other.
I'm doubtful. You guys have made yours work for a while. I think we're going to find out how these new compacts work. I was wondering if there's not like a need for one big entity to coordinate those.
We've talked about it, and the problem is too many standards that have to be reconciled among credentials, and I don't know if there's any way to bridge all those problems.
Oh, sorry. Whoever said American Dental Association, thank you. And this actually highlights the example of why it's important to have different licensure groups part of CTeL, because ADA was part of CTeL at one point, and now they're not. But I think one of our goals has been over the last couple of years is to really bring in all of these different trade associations into CTeL, because I'm sure there's issues that impact ADA that we're not even thinking of.
Audiologists. I mean, it's
yeah. We do have to have someone. We do have to have those. Who represents at a federal level those with disabilities or underserved?
American Council. Or is American Council on Disability, is that a private or?
Oh, okay. Then I'll add them under association, but I'm just wondering if there's a federal agency that does it.
Does the Department of Labor do that sort of thing?
Yeah, there's got to be. That's a good.
Oh, that's actually a good point. We don't have DOL on here.
You have the Agency of Community Living that's in HHS too. That doesn't a lot of.
What do they do?
We could probably get the National
Access is
Mayors
what they would say
Association.
when I worked there, but I didn't work in their bailiwick very much.
What is that mayoral, National Mayors Association?
I don't know.
Okay. We might want to. Okay.
They do a lot of disability like work.
Okay. So yeah, that would be a good fit.
Okay. I just want to make sure every group is represented. Well, overarching groups are represented. All right. So
This is our recommended list, right?
right, and this is a draft. So
There's something called the United States Conference of Mayors.
That's it.
You have the Student National Medical Association.
no. Thank you, Taylor.
Yep. Want some patient advocacy orgs too, but I don't know that we could sit here and name all of them.
Yeah, or even a representative sampling.
There's the International Federation of Medical Students Associations, several countries.
Okay.
Medical school. Is that what he said?
Students.
Oh, students.
Okay. Bye, Marshall. All right, so we have about, oh gosh, we have about only 15 minutes left. Okay, so all clinical providers, the three main topics there are pipeline retention and public protection. Pipeline retention and public protection. Those are our three overarching issues that are impacting the clinical workforce shortage. We are asking for an is this the right terminology, Tate? Interagency federal and state coalition? Or is it it wouldn't be interagency, it would be federal interagency and state coalition, right?
Yeah.
Federal would go first.
Intergovernmental.
Can you say that one more time?
Intergovernmental and public, commission. We had access after protection and access, right?
So we have the main categories are pipeline retention and public protection.
Pipeline is access.
Pipeline is part, yeah. But how do we phrase this? Because I want to make sure that I get the terminology right. Are we still asking that they declare a public health emergency? Are we, well, let's get to what it's called first, and then I'll jump in here.
It's the Intergovernmental Public Commission. I was looking at.
Intergovernmental public. Is that the whole?
Council.
Okay.
Pick a C word.
So it's we request that HHS create and fund an intergovernmental public commission.
Okay.
So we want to remove intergovernmental would include state representation. Okay, so we don't want to spell that out individually. HHS create and fund an intergovernmental state and federal public commission.
I think intergovernmental just in itself is inclusive of local and federal, but you could.
Do we want to call it a public health commission? If we're going to be declaring.
Well, hold on. And state intergovernmental public health commission for the purposes of reviewing the declaration of a public health emergency, or do we want to say CTeL would like to request that HHS create a public health emergency in order to fund? Actually, they have to declare.
You don't want to be creating another.
Good. That is a very good designation.
Thank you to the attorney.
Very good clarification.
Why I did not finish law school.
I think some groups are going to have reservations about declaring a public health emergency.
Yeah.
I need to talk to our team or board before going too far down that.
So we would likely, I think we've got nurses on and other associations on. Is it safer if we're still at the same end, aren't we? If we're the public health crisis, but then that doesn't allow for the funding of this coalition. The whole point is to open up funding.
Yeah.
And if we don't declare it, then we can't fund it.
Yeah, I agree. And I think especially with Hannah's presentation last time, I know the scope of practice and has been a concern for everybody. I think we've hopefully put that to bed, right? That's a state licensure issue.
Yeah.
The federal government can't do anything to decrease the quality of care. Yeah.
Right.
Yeah, shouldn't it? It can't. So I think, so hopefully a lot of those concerns have been addressed and alleviated. It's definitely a big deal if we're going to say public health emergency. So I don't blame any group to say, well, we need to talk about this.
I think what people worry about is the other flexibilities they may have beyond or try to exercise beyond funding the commission. I think based on my conversation or when the colleges of nursing were here, I think they were worried about changing revenue streams within HHS in relation to Title VII and Title VIII.
But the public health emergency could be whatever you want it to be, just like the opioid has very limited jurisdiction.
I mean, I think maybe public health, designate a public health emergency in order to fund, but not like speak to broader.
Okay.
Yeah.
Designate a public health emergency in order
to fund this coalition. Because I don't think anybody wants to take funding away from anything else.
to fund the creation of a federal and state intergovernmental public commission to address the clinical workforce shortage.
Yeah.
But it's not strictly intergovernmental, is it? Because we've got all these other groups.
Intergovernmental and public.
Yeah, intergovernmental hold on. I need someone to wordsmith
We
this
could just
with me.
break it back out. We could just say federal, state, and public. If we need to. I like the word intergovernmental, but if that's.
Is there a legal reason we would want to use intergovernmental compared to?
I mean, I think we're using intergovernmental just to span different agencies and state and local governments. But if we wanted to spell everything out, you could get rid of intergovernmental.
So it could say, we would like to request that HHS designate a public health emergency in order to fund the creation of a federal, state, and we want to put academic here because public almost.
If you're gonna do mayors, you might do state and local.
State.
That's a good point.
But then it becomes so
Intergovernmental
big.
really is the better word.
That's why I liked about the word intergovernmental.
Yeah, it really is. the
Okay,
better
let's go
word.
back to intergovernmental.
Yeah.
Who else is like, is anyone is everyone like paying attention? Because this is some really exciting stuff. Like, as we're wordsmithing it.
Yeah.
The creation of intergovernmental and public, intergovernmental, academic, and public commission to address United States clinical workforce shortage. United.
Yeah.
States long established, ongoing, or just clinical? Do we want a qualifier before clinical workforce shortage?
Chronic.
Drastic crisis.
Well, healthcare is broader, clinical limits it.
Right. Okay. We would like to request that HHS designate a public health emergency in order to fund the creation of an intergovernmental academic and public commission to address the United States chronic clinical workforce shortage.
Just for the sake of economy, I
Yeah,
would get rid of would like and we'll get rid of in order.
okay.
But for me, at least, doing what you're trying to do right now is a lot easier when I'm.
Okay, I'll send this over to you. Yeah, yeah, we're not gonna finish this, but we have 2 minutes. We're not gonna finish this, but. Yeah, all right, so we have a good roadmap, way better than we did in June, far better than we did in our first conversation. I appreciate everyone actually literally rolling up their sleeves and working and contributing to this document. Do we have any final thoughts from those that are participating on the call? I know that we want to add quality in here, and that could be included in the actual write-up. And I'm going to make note of that.
I've got one. I'm a veteran. The VA Office of Workforce Management and Consulting is the office that actively recruits IMGs. I might give the guys a call.
Thank you, David. I appreciate that. And David, if you want to send me any other information regarding because you've worked really closely with FBI over the years, if there's any point of contact, we could potentially go to a meeting together. Oh, David, you're on mute.
Okay, they have a big organization supporting something called Wrap Back, which means the rap sheet comes back. It's an automated system that VA automatically submits inquiries to itself periodically to check and see if any disqualifying offense or other criterion has occurred, and then notifies the sponsor. This is something we want to push to the various international compacts and things. And there's also the absurdity of the whole thing that all these international graduates and stuff, some have never been and never will come to the U.S. yet. They only require the FBI check for a rap sheet, which none of them ever has. And yet we deal with the Royal Canadian Mounted Police, Europol, Interpol, the strangely named ones for all the friendly countries all the time. And nobody wants to get a background check from them. That's crazy. That's all.
So I don't want people jumping off it and leaving this meeting, because the next session, this part of the session 6, which is actually creating the framework, has concluded as of now. But then we go into the next part and talking about just one of the components, and that is enforcement and compliance considerations as it applies to reimbursement. So that's one of that is under retention, and that's under retention. Did I?
We can talk.
Yeah. Okay. I mean, all right. Why don't we take a 15-minute break and everybody come back?
So is this now?
No. It's still. I'm just saying reimbursement in general has applicability to
enough?
We are,
It's a lot.
I don't know if we'll need to.
I don't think so.
all right, welcome back, everyone. Thank you so much for joining us for our final session today. It's been a very productive roll up your sleeves type of meeting this morning. Our last session is brought to you by experts